Hello and welcome to OB Survival Skills. Today we're going to go over some of the skills and information that you need to be successful in your first week of clinical. So we're going to talk about MOM with labor, the labor board abbreviations, some fetal monitoring, the postpartum assessment, some little information about breastfeeding, and some information about the baby. So the stages of labor is where we're going to start. So when we think of labor, a lot of times we think about the movies and the woman's water breaking and her proceeding to have a baby a few minutes later. Unfortunately, that's not how it really happens for 99.9% of people. So we have various stages: stage 1, stage 2, stage 3, and stage 4. Stage 1 is actual labor, and there's the latent phase, which most current research states that it's when contractions start to about 6 centimeters. There's the active phase, which is about 6 centimeters to 7-8 centimeters. And there's the transition phase, which is transitioning from being in labor and that cervix opening up to pushing. Stage 2 is pushing. Stage 3 is from the birth of the baby to the birth of the placenta. And stage 4 is the couple hours afterwards until we determine that the mom is stable and ready for transfer. So I mentioned dilation. When we talk about dilation, we're talking about cervical dilation. So you can see here a few different visuals to think about what cervical dilation is. So when we're checking a cervix, we are placing our fingers inside the vagina. We use 2 fingers, and then we're feeling for the cervix. The cervix is firm and soft, whereas the vaginal wall is more soft and, is rough and kind of gushy. So the cervix is firm and soft. And we communicate about dilation via centimeters. 1 centimeter is if one finger fits through, as you can kind of see on this picture here. 3 centimeters is when 2 fingers fit through. And then it gets bigger and bigger and bigger. 10 centimeters, although it usually is 10 centimeters, is really when the cervix is completely gone. So you can kind of see how this might be a little bit subjective as opposed to objective when you get into kind of the 5 to 7 range. So you might hear some discussion about that on the floor when patients are in that range. When somebody else checks them, they might not come up with the same exact dilation, which is okay. It's best if the same person checks them consistently so that they know if there really is change happening. And we care about cervical dilation because we need the patient to have that cervix be completely gone before they start pushing. Otherwise, they're going to cause trauma to the cervix, and then we're going to be in all sorts of trouble. So we have, when we're talking about a cervix and a vaginal exam, we talk about 3 different things: the cervical dilation, the effacement, and the station. So here's a good visual of effacement. And effacement is the cervix thinning out. So you can see here in A that there's an internal os and an external os. And although this external os is dilated, the internal os is not. So this patient would be closed. And this is the cervix. So this patient is probably like 3 or 4 centimeters long as opposed to any centimeters open. Here we see the internal os is way up here and the external os is down here. And now we see some opening. This patient's probably about 4 centimeters and about 50% effaced. And then here we have the same thing where we have the internal os way up here and the external os down below. And so we're getting probably 80% effaced, and this one I would say is probably about 2 centimeters. And then here you can see just a little bit of cervix here. It's probably 100% effaced and 9 centimeters dilated. And here's just another visual of that. You can see the cervix nice and thick and firm here, and it's kind of melting away here. This right here is the amniotic fluid sac, so we call it the bag of waters, in front of the baby's head. So this would be called a bulging bag of waters. So station is used to tell us where the baby is in relation to the mom's pelvis. So we call 0 where the ischial spines are. So you can see here this picture where the ischial spines, that's a 0 station. And we take our station off the baby's head, not their caput. And you're going to learn more and more about that term caput. But caput essentially is swelling on top of the head. So we're going to use the skull bones as our reference point, not the swelling. So we need to be able to push and make sure that we are feeling for the baby's skull, not the swelling, to determine the accurate station. We like to start pushing when the baby is at about +2. And that really helps mom to decrease her pushing time and decrease the energy expended, and it increases vaginal delivery rates. And here's just another diagram of it. So I like this one. It's like fishing. So at 3, you're floating high. At -2, you're in the right direction. -1, you're settling in. 0, you're halfway there, then inching out, nearly there, and get the crown, because at +3, they're going to be crowning. So and crowning is when we see a good portion of the baby's head outside the vagina. So some things we're considering when we're looking at mom, and here's some of the abbreviations. So when we're looking at the labor board, which tells us what's going on the floor and what's going on with our patients specifically, we have some abbreviations that are common in this area that you need to know. So EDD is estimated date of delivery. EDC means the same exact thing. It stands for estimated date of confinement. And EDC is an older acronym, but it's still utilized. And the reason why is because they used to literally confine women to the bed. It was called the knock 'em out, push 'em out method. So in the kind of late 40s, 50s, they would knock women out and push their baby out for them. We luckily have far better ways of providing pain relief at this point in time, but they wanted the woman confined in a couple different senses. The woman should be confined to the bed. And then in addition, when she got closer to her due date, they wanted her to stay home and not go anywhere. So another sense of confinement. AROM and SHROM are ROM in that both mean rupture of membrane. So it's when the water breaks. A is artificial, so artificial rupture of membranes, which indicates that either the midwife or the MD went in with a tool called an amni hook, which we will show you, or an amni cot, and actually went in and broke the water. SHROM, or spontaneous rupture of membranes, is that the water broke all on its own. Nobody used a tool to break it. SVE is sterile vaginal exam, and SSE is sterile speculum exam. So we do speculum exams on women who we think might be ruptured or are in preterm labor to do some tests there. A CLE is a continuous labor epidural, and that's what's going to provide the mom pain relief if she so desires. And then we have gravida and para, and you'll hear it referred to as G's and P's. Now, we're going to talk in class a lot about the long form of it, the GTPAL, but on the labor boards, all we do is G and P. And when we're discussing our patients and giving an S-bar, we are pretty much only going to be discussing the G's and P's. There might be a few special circumstances where we go into a little bit more detail, and we'll discuss that later, but from a survival skill knowledge point, G's and P's. So G is gravida, which is the number of times the mom has been pregnant, whether that pregnancy ended before the birth of a live baby, or whether we're at the end of that. So let's say we had a mom who had a spontaneous abortion at 10 weeks and is pregnant now, she would be a G2 because she's been pregnant twice. The para is the number of births. So she would be a G2 P0 because she has not given birth yet. A birth is considered anything greater than between 20 and 24 weeks. There's differing opinions on that, but don't worry, neither I nor the NCLEX will give you anything that wouldn't be crystal clear. So for meds, we have a lot of different meds, and one of your assignments this first week before we go to clinical is actually going to be to complete a med list. So we're Pitocin, magnesium, those are all part of it. So you can take a closer look at that a little bit later. Another acronym that you might see, which is listed here with the meds, is PTL, which is preterm labor, PIH, which is pregnancy-induced hypertension. Then we have DFM, which is decreased fetal movement. So if the mom's not feeling the baby move quite as much as usual, we want her to come in and be assessed. And so DFM is how we annotate that, how we denote that. CTX is contractions, and CRB is a cervical ripening balloon. It's also called a Foley bulb. And I put a picture here of the cervical ripening balloon just so you could kind of visualize it. And it's called a Foley bulb or some people refer to it as a Foley bulb because that's what we first started using when this intervention was utilized, is a Foley. We would put a Foley up and blow up the balloon and hang a 1,000 milliliter LR bag from it to give it a little bit of tension. So, and then of course, somebody decided they would make one specific to labor to put pressure on both sides and charge 50 times more for it. So they're doing well, but we do utilize these a lot, and Tri-City does utilize these. So you might see patients who are being induced with the cervical ripening balloon or the Foley bulb. Fetal monitoring. So the majority of the L&D nurse's job is to monitor the baby. All of their nursing interventions, or not all, but a lot of their nursing interventions are based off of what that baby is doing. So there's different ways that we can monitor. There's fetal heart rate auscultation, which can be done with a fetoscope, which we'll show you later, or a handheld Doppler. And then there's external monitoring, internal monitoring. In the next slide, we'll show you pictures of those. And what we're looking for is variations in the fetal heart rate in relation to the contractions. So we have accelerations where the heart rate goes up, and a little smiley face, we like those. And we have a couple different types of decelerations, although not all are bad. Early decelerations are head compression. Late decelerations, we don't like. Early decelerations, those are good. That shows that the baby's coming on down. Late decelerations, those are going to show us that there is uteroplacental insufficiency. It's not good. Now, there can be causes of it that are completely benign that we can fix, or it might be something that we just need to surgically deliver the baby. A variable deceleration is due to cord compression. So that cord can be wrapped around the baby's leg, around the baby's neck, around the whole entire body, and it might be getting compressed. Those, most of the time they're benign, but they can become detrimental to the baby if they're occurring too frequently and going too far down. So if the deceleration is going down into the 30s, let's say, the baby can only sustain that for so long. And then prolonged. A prolonged deceleration is when the heart rate goes down and just stays down. We'll give you some visuals here. So here is the external monitor. So we have an ultrasound transducer that is placed on the mom's abdomen, and a toco transducer, which is placed on the mom's abdomen as well. And you can see that with the ultrasound, so right here, this would be the ultrasound, this is the toco. The toco we place up at the fundus of the uterus, because that's what gets hard during contractions. And the ultrasound monitor is typically lower, it's usually below the umbilicus to one side or the other in a full-term patient. You can see here that we're actually getting the heart rate through the baby's back. So when mom flips to her, let's say, to her left side, we're going to put the monitor on her right side because the baby is going to be, that's where the baby's back is going to be. And this is showing us some internal monitors. So here we have a IUPC, which is a intrauterine pressure catheter, is what we refer to them as. So here's the catheter, and that goes up into the uterus. And then we have an FSE right here, which is a fetal scalp electrode. And the fetal scalp electrode goes on the baby's head right here. And I will let you touch and feel these in our survival skills in the labs, so you'll have an idea of what exactly this is. So we talked a little bit about the strips and what they look like, and here is the difference between the external monitor and the internal monitor. Now, honestly, the external monitor, we're never going to see contractions look this big, at least not very frequently. The internal monitor, not big, I'm sorry, this good, like a perfect bell curve, it just doesn't happen with external monitors. It should happen with your internal monitor though. And we get just a little bit more beat to beat variability with the internal monitor than we do with the external monitor because it's an actual electrode. It's picking up the actual heart rate as opposed to the sound of it. So here's some accelerations, and you can see we have our baseline here of our heart rate. So this would be a baseline of about 130. And then we have the heart rate go up. And an acceleration needs to be 15 by 15 to be considered an acceleration in a full-term person. So that means that it needs to go 15 beats above the baseline, and it needs to last for at least 15 seconds. So both of these are qualifying accelerations. And if we go back one slide, you can see what the strip means. So these big dark blue lines, this is 1 minute. And each little individual box is 10 seconds. So we talked about early decelerations and those not being bad. And here's an example. It's a drawn example, but an example nevertheless of an early decel. So what's happening here is that the head's being compressed, and it's a vagal response. When your head's compressed, your heart rate and blood pressure go down as well. So we have head compression. So we're going to see this near the contraction. So you can see that we have the onset at the beginning of the contraction and recovery by the end of the contraction. And that's consistent for all of these decelerations. That's different from these late decelerations. So like I mentioned before, the late decelerations have to do with the uteroplacental insufficiency. So here's the placenta here. And that means that the baby's not getting enough blood and oxygen. So here we see that the onset is late, which is one of the reasons why they're called a late. So we have late onset. It's usually about halfway through the contraction, and a late recovery. It takes the baby a little while to recover. So this is what we're seeing for all of these. We don't like lates. They're not good at all. And here's a good way to remember it. So it's okay to be early for dinner, but don't be late. And we have variables, and a good way to remember variables is that they look like a V, because most of them do. They look like a U or a V. And this is going to be umbilical cord compression. So you can see in this picture here, the umbilical cord is like around the baby's leg. And so you can imagine when the top of that uterus contracts, that cord is going to be compressed. And so the blood flow is going to stop. But we have good coping mechanisms in that the heart rate goes down, so the baby's like, I don't like that, and moves away. And so then the heart rate comes back up, but then it can happen again, or they happen with a contraction only, and it's due to the contraction compressing the umbilical cord. Again, we're not terribly concerned with variables. When they happen randomly, when they happen like this with every single contraction, we're going to do some interventions to help stop those. Our primary intervention whenever we're having any sort of fetal heart rate issue is turning the patient. So we want the patient to move. We're going to put her on the complete opposite side that she was on. If it doesn't get better, we're going to turn the patient again, because a lot of the time it has to do with the position of the baby. So this is a good actual depiction of some decels. Now, these are late in nature, but they're considered prolonged decelerations because they're longer than 90 seconds to 2 minutes. And again, the research varies. We're going to go with 2 minutes. So if a deceleration is longer than 2 minutes, it's considered a prolonged decel. And these would be considered late prolonged decelerations, because you can see here the onset is about halfway through the contraction, and it just takes a really long time for that baby to get, baby doesn't even fully recover before the next contraction, then baby's down again. So that was a lot of our labor stuff. That's just some basic stuff for you to know. And I have a fabulous handout that I'll give you that goes over a lot of the fetal heart rate information that you can utilize while you are in clinical. So to the mom, what we're looking at here is the postpartum assessment. So after mom has had the baby, placenta's come out, she's had her laceration repaired if needed, she's had bonding time with the baby, and we've determined that she's stable. Then we transfer her to postpartum. And the postpartum assessment is something that you're going to be doing on the postpartum moms. And this is what we focus on. And it has a nice little acronym here called BUBBLE-HE. So we're looking at the breasts, the uterus, the bladder, the bowel, the lochia, the episiotomy or laceration, which is that last E there, Homan sign, and emotions. Now I'll say, we say episiotomy / laceration because episiotomy is when the physician cuts, and a laceration is when the woman just tears naturally. There's a lot of hot feelings, I guess would be a good way to say it, about episiotomies. People are very upset if they receive an episiotomy. So when you're doing your assessment, think to yourself, okay, yes, my acronym tells me episiotomy. All that really means in the postpartum period is that there was some sort of tear that needed to be repaired, whether it was man-made or whether it was natural when the baby came out. In the postpartum period, it doesn't matter at all. But that's just how our lovely acronym works. So, and we are going to look at the breasts first. We're going to start head to toe in our assessment. When we assess the, go back here for a second. When we assess the breasts, what we're looking at is symmetry. We're looking to make sure the nipples aren't cracked and bleeding. We're looking to make sure that she's not overly engorged. And we're going to talk to her a little bit about breastfeeding. And I'll give you some of those pearls at near the end of this. As for the uterus, we're checking the fundus, and this has been happening since she gave birth. The labor and delivery nurse is checking the fundus, and now we're checking the fundus in postpartum. We want the fundus to be central, and we want it to be at the U or below. And you can see how it, it's called involution of the fundus. So you can see how it comes on down here. So when we're doing fundal checks, we're also going to be talking about the bladder, because if our bladder is full, our uterus is going to be displaced, and then we're going to have more bleeding than we want. This is an example of how to do an adequate fundal check. Sorry, those words kind of got cut off there at the top, but this is, you're going to provide counter pressure, which is supporting the uterus so we don't prolapse it. So we definitely don't want to prolapse the uterus. And what we're doing is feeling the top of the fundus. So you'll have an opportunity to do this on our mannequins before going to clinical. And we have a fabulous example that lets you feel really a very similar feeling of what it is. And this is a good example of how the bladder can displace the fundus, because the full bladder will make that fundus move. So for the bowel, what we're going to talk about is we want to know when the last bowel movement was. We want to encourage moms, especially moms who had any sort of laceration or episiotomy, and that had any sort of repair, that they take the stool softener, because there's kind of a stigma to taking stool softeners for some people, but it's so important because we don't want them bearing down too hard to have those bowel movements. We want to make sure they're having bowel movements, especially our C-section moms, because they're going to have some serious deferred pain if they're not getting things moving pretty quickly. While we're discussing their bowels, we're also going to take a look at their bum. and make sure there's no hemorrhoids. Or if there are hemorrhoids, we're going to take a look at them, make sure they're not bleeding, and assess them, and potentially have the physician come and take a look if we think that they might be bad enough to warrant some sort of intervention. So for the lochia, that's the bleeding after birth. We in the hospital are just going to see rubra unless we have some random situation where the patient's there for 5 or longer days, which doesn't happen very often, even with C-section patients. So we won't really see the serosa or the alba, but we will definitely see the rubra, which is a red color and looks just like blood.